Question number 1 is a patient with a carotid stenosis being evaluated for possible revascularization. Which of the following is symptomatic? Counts as symptomatic for having that carotid stenosis. Vertigo last week with a 90% right carotid stenosis. Ipsilateral transient monocular blindness 1 month ago. 3, hemisensory loss 1 year ago. 4, expressive dysphagia 7 months ago. 5, 1 and 2. 6, 2 and 4. Or 7, 3 and 4. While you're contemplating all that, just as an aside, the boards won't ask questions written this way. They won't do these K-type questions. They'll have 4 answers that you have to choose between the 4. But this is a good test of whether you know what symptomatic carotid stenosis is. Yep. So people are there seems to be consensus building around 2 as being a possible answer, but there's some confusion about the rest of it. All right. Number 2, a 73-year-old male referred 2 months after right carotid territory ischemic stroke affecting his left arm and leg with good recovery. The ultrasound indicates an occluded right internal carotid artery and a 40 to 69% stenosis of the distal left common carotid artery, which is correct. Right carotid endarterectomy is indicated to reduce recurrent stroke risk. Stenting would be a reasonable alternative if there were high-risk features for surgery. 3, carotid angiography should be performed prior to making a decision. Or 4, revascularization is not indicated. Okay. And the last pretest question is a 72-year-old, 80-kilogram male with prior AFib presents to the emergency department with new aphasia and hemiparesis. Last known normal was 4 hours ago. CT scan shows no cerebral hemorrhage and an M2 occlusion. A treatment center with expertise in stent retrievers is 1 hour away. The patient's blood pressure is 170 over 100. His INR is 2.2. His glucose is 105. What is the next best step in the management for this patient? Is it alteplase 72, alteplase 90, transfer for stent retrieval of the intracerebral clot, administer the alteplase at 72 and transfer for the thrombectomy, administer alteplase 72, transfer thrombectomy if no clinical response at 1 hour? All right, so Dr. Peter Pollack is an interventional cardiologist who also happens to work at Mayo Clinic, Florida. He's trained in all areas of intervention, and we've asked him to speak both today on renal and carotid disease and tomorrow on some of the acute coronary syndrome things. So Peter, thank you so much for coming back to Rochester and for helping us understand these complicated topics.
All right, thanks so much, and thanks to the audience for hanging in there. It's late in the day, and it's been a long day, so let's stick with where we are outside the mediastinum. So we have a number of learning objectives. The first part of the talk is going to focus on the management of carotid disease, both asymptomatic carotid lesions, symptomatic carotid lesions, with emphasis on distinguishing between the two, and then the management decisions that follow from that, with a focus on how we decide between carotid endarterectomy, surgical revascularization procedures versus carotid stenting or percutaneous, and this has been an area of evolution. The next part of the talk, if it's divided into 3 parts, is going to be about acute stroke and really the management decisions that we need to know as cardiologists for the boards. And finally, we'll end with renal vascular disease and talk about management there and some of the do's and don'ts. So let's start with the carotids. I think, especially with the cardiology audience, it's important to emphasize the anatomy since we're well outside the mediastinum. The common carotids arise on the right from the innominate artery, the left directly from the aortic arch in usual anatomy, and then it bifurcates. Remember, bifurcations are where atherosclerosis likes to build up and where we get our plaque. So it's splitting into the external carotid that goes to the face. The internal carotid is the one that we're worried about mostly because it goes to the brain. Most of the plaque buildup happens around the carotid bulb near this bifurcation, and that's what we're going to focus on. If we think about a plaque in this area, in this cartoon, we have to decide how much stenosis is there, and you may see this again. So we'll have to decide on a denominator. So we can pick the narrowest point, and then we have to say, well, that's narrow in reference to what? And so we have to pick the reference diameter. And there have been a number of different ways to do this over time. There was a common carotid method, kind of ignoring the external bifurcation. And then really the established method is from the NASCET trial, and this uses the nearest distal normal vessel. So since so much of this is in the what we consider the ostium of the internal carotid artery or right at the bifurcation, there's often not a proximal stenosis area, a proximal area of normal vessel. So we're going to look at the closest distal area of normal vessel, and that's going to be our denominator to figure out how stenosed that area is. So what is symptomatic carotid disease? And this is fundamental to answering all these questions correctly. So it's ipsilateral amaurosis fugax, which I practice saying, and that's the nightshade coming down over the eye on the same side as the carotid. We're thinking about plaque that broke open, led to thrombus formation, and embolized somewhere up into the brain. So think anatomically. Remember that the left side of the brain controls the right side of the body. So if we're thinking the left carotid going to the left hemisphere, it's going to control the right or contralateral motor and sensory symptoms. And dysphagia, you can get the language centers occur on both sides. There's a left-sided predominance, especially in right-handed people. So we're going to look within 6 months. And so if it's been longer than 6 months, they fall back into an asymptomatic categorization for decision making. Dizziness, syncope, pre-syncope, these are not considered symptomatic events because they don't tie to a focal neurologic territory. We will see that vertigo is more posterior vertebral basilar, not carotid associated symptoms. So what do you do with a chronic occlusion or carotid occlusion? Remember, similar to coronary occlusions, a fully closed vessel when it's not happening acutely in front of you, this is a very stable thing. This is a very stable state. So completely occluded carotid arteries with stable neurologic status do not need to be revascularized. There is the circle of Willis, which is built-in anatomic collateralization to the brain. We have the vertebrals in the back and the carotids in the front. So if you lose one and the circle of Willis is supplying flow to all areas of the brain, then you really shouldn't open that occluded vessel because you risk embolization to the unprotected areas of the brain. So as we emphasize between symptomatic and asymptomatic carotid disease, remember the 6-month cutoff for timing. And we're going to talk about how the severity of stenosis, so as that plaque builds up, as the velocity is going past it and the associated shear forces increase, how that increased severity of stenosis affects the likelihood of symptomatology and the likelihood of stroke or TIA. When we look at symptomatic carotid disease, the much higher risk group compared to asymptomatic patients, then a meta-analysis of trials, we're going to see the strongest treatment benefit. This is endarterectomy or surgical revascularization versus medical therapy. We're going to see that just on medical therapy, they don't do nearly as well as asymptomatic patients on medical therapy. And you're going to see that there's the greatest benefit to revascularization with surgery. So these curves separate dramatically. So a lot of benefit to surgical revascularization in the symptomatic patient. We're going to see that as the carotid stenosis increases, especially on the right side of the table, that's where we get our substantial or significant benefit to revascularization. Their stroke risk is higher, and thus their benefit to revascularization is also going to be higher. You can see on the left side, stenosis less than 30% confers some protective benefit and a negative risk ratio. Now, this almost looks linear. You can see that as we go just in the cohort of symptomatic patients with greater than 50% stenosis, that risk continues to march up as their stenosis severity increases from 10% per year in the 50 to 69% category, all the way if we get over 90%, then a third of the patients are going to have an event within 2 years without endarterectomy. So as the stenosis severity increases, their risk of event increases. And thus, the benefit from revascularization improves. If we look, this is number needed to treat with surgical revascularization. And we see that, again, both of these are indicated greater than 50%, but the benefit is much stronger as we get even greater than 70% fractionated from those in the 50 to 69% category. So as their risk goes up, their benefit to revascularization goes up, particularly with the symptomatic group. So some pearls for boards: high risk of major stroke and death. These are the sickest group of the patients with carotid disease. The highest risk is within 6 months. If they've gone 6 months without an event, they're back into the asymptomatic category. And we have to think about them that way. We get more disease and more risk of stroke or TIA with increasing severity of stenosis, especially significant over 50%, and that's where we get our indication to intervene, and our class 1 indication for revascularization greater than 50%. With mild stenosis or complete occlusion, we don't recommend revascularization. Now, switching to asymptomatic patients, these have gone either more than 6 months without an event, or their neurologic symptom is not attributable to their carotid disease. We have to remember that they're still a sick group of patients. They have peripheral arterial disease. A carotid bruit confers significant elevated risk of death, MI, and stroke because peripheral arterial disease is everywhere in the body. The majority of strokes are going to occur in other territories because it's not just that carotid that's causing the disease, and the minority of strokes are attributable to just one carotid stenosis. It's different than coronary disease that way. It should prompt optimal medical therapy, and as you're looking at questions on the boards, when you see an option in an asymptomatic patient for optimal medical therapy as the next best step, and they're not on it, that's probably a good way to think about answering. So population screening, because the association between carotid stenosis and ultimate disease in asymptomatic patients is weak, then population screening doesn't work very well, and there's diminishing enthusiasm even in targeted populations. So you find a bruit or you find incidental carotid stenosis, you should treat these people for their vascular disease and for their risk factors aggressively. But just relieving that carotid stenosis because we happen to find it either by listening or looking doesn't mean that they need revascularization. And you'll hear that as a theme. If we compare these curves, this is surgical revascularization from some older trials, ACAS and ACST, combined. These curves don't separate very much. So again, in the asymptomatic patient with carotid disease, surgical revascularization doesn't help very much. So we would expect that stenting may not help either, and we'll talk more specifically about stenting in the next section. This is a busy slide, just for your reference mostly. I think the important takeaway here is that the risk of stroke with medical treatment alone, and this is older medical therapy, was 3% per year. I don't get to do jazz hands like my wife, but I'll just say 3% per year. You may hear it again later. This is reduced to 2% by endarterectomy, so really not a dramatic improvement because the attributable event rate from those carotid stenosis in asymptomatic patients really isn't that strong. Again, CREST-2, and we'll highlight it's an ongoing trial, but it's important to understand because it emphasizes the presence of clinical equipoise in our practice, and I think that equipoise is testable, is ongoing and rolling, and we'll be looking for the results of that. I'll explain how that trial works in a few minutes. So let's go on to just some principles of revascularization with carotid disease. We're all cardiologists in the audience, and I think it's important to highlight some ways that it's similar and different to epicardial coronary stenosis. So we're used to thinking about angina and myocardial infarction from epicardial coronary disease, where that's the attributable cause in 90% of the time, whereas in stroke, it's more like a quarter of the time that cervical carotid disease is the culprit. There's too many other causes, other sources of atheroembolism that can lead to TIA and stroke, so the attributable risk is much different. We think of stenosis leading to ischemia, but really stenosis in the carotid, this isn't a 2 or 3 millimeter vessel, it's a 7 or 8 millimeter vessel. Stenosis is leading to increased shear forces over the plaque can break open, expose thrombogenic material, but then that clot that forms doesn't block the vessel, it embolizes downstream. And so occlusion of the carotid really is a minority. It's less than 5% of strokes, whereas occlusion of an epicardial vessel causes a heart attack the majority of the time. Revascularization in a heart attack is meant to improve blood flow. It's a mechanical opening of the vessel. Revascularization here is meant to improve laminarity of flow. It's meant to reduce embolic risk by trapping and moving the thrombogenic material out of the way. And if we look at our two options here to transition into endarterectomy versus stenting, we're going to see that a lot of our data is something we can anticipate from just the logistics of how we do each procedure. Carotid endarterectomy is an open procedure requiring general anesthesia. They have to cut the neck open. There are nerves that are important right on top of the carotid we have to avoid in order to avoid nerve injury. They then take out the plaque, so they adequately remove the plaque. They have better proximal and distal control of the vessel to minimize embolization during the procedure. But again, it's an open procedure, cutting open the neck to get there. When we do carotid stenting, this is a percutaneous procedure. It's done predominantly from the leg. You can see on the top one of the stents. These are self-expanding stents that are meant to trap and push the plaque out of the way so that we don't get the plaque rupture with atheroembolism. And then we use embolic protection devices like the umbrella device you see underneath to minimize, as we manipulate the plaque, which we have to do even to get the embolic protection device into place, that we minimize the chance as we're manipulating the plaque of causing some embolism in the process. So when we look at procedural risks, these again are appreciable from the way that we do it. There's a clamp time of about 30 minutes. You can get some post-op thrombosis, but really one of the big risks with endarterectomy or surgical procedure is the anesthetic risk, the swings in blood pressure from manipulating the carotid bulb, and associated myocardial infarction. Cranial nerve injury, wound healing, these are all things that are appreciable from an open procedure. The stroke risk is somewhat higher consistently with stenting because we have to manipulate our way past the plaque on the inside of the vessel. And of course, there are going to be access site complications that you don't have from femoral access that you wouldn't have with surgery. This is an example of a patient's arch. You can see the extensive disease. We have to manipulate our catheters around the arch to get up into the carotids from inside, and this is going to be part of the increased risk of stroke when we look at carotid stenting trials. There have been a number of trials looking at surgery versus stenting. I'd like to distill the data to what I think you should need to know going into the boards to get the right answer. We're going to look at symptomatic versus asymptomatic patients and highlight some of what we already talked about, and then surgical risk that are high surgical risk and not high surgical risk. The first thing to remember is that we have to consider with the procedure, what are those features that increase the risk of surgery? And I think if you think about laying someone down, putting them under anesthesia, cutting their neck open, you can think it makes sense what things would make a patient that you're considering to send for endarterectomy higher risk. Well, if the lesion is very high towards the base of the skull or very low below the clavicle, it's hard to get to. If they can't flex their neck, if they have a tracheostomy, they're going to be increased risk of wound infection. If they have a contralateral laryngeal nerve palsy, then if you hit the one on the side of the surgery, then they're going to be at risk of laryngeal spasm and airway problems. So, and physiologic, older patients, sicker patients, those with low EFs, are all going to be at higher surgical risk. You just know intuitively the patients that are not going to do well with surgery in general, and these are the ones that were studied first. Importantly, vascular surgeons are increasingly comfortable with operating on dual antiplatelet therapy. As you heard in the last lecture, we do use dual antiplatelet therapy in these patients a lot of the time. They have disease in their carotids, they also have it in their hearts, they may have had stents, and so the presence of dual antiplatelet therapy should not deter someone who needs surgery on their carotid artery. The Sapphire trial was one of the earlier pivotal trials and looking at carotid stenting versus surgery, and really established that stenting can be done with was non-inferior to surgical endarterectomy. It looked, as you would expect for an earlier trial, at just high surgical risk patients. We just saw the table of what high surgical risk means. And in the randomized cohort, this is just 167 patients that were successfully randomized. So the trial really suffered from slow enrollment into the randomized arms. You can see that in yellow, carotid stenting was non-inferior. It looks a little bit better, but the p-values show that it was just tested to non-inferiority. And then even more patients than were randomized were entered into the surgical registry, and those look better than the surgical patients that were randomized. So there is some clinical intuition that can go into steering these trials, and we'll see that as a theme throughout a lot of trials. There have been a number of other trials that have been looked at. A lot of them are controversial. I'm not sure they need to be expressly known for the boards. It's important when you look at these trials to look at how much embolic protection device was used, because we know that's an important mechanism for reducing the risk of embolic stroke during the procedure. The experience of the operators, whether that was mandated, whether they had a team approach. So this mired a lot of earlier data. The CREST trial was really meant to answer this question. This was one of these large prospective multi-center randomized controlled trials, predominantly in the US. It involved a kind of team approach, the same team approach that we saw in Syntax, the same team approach that's done in partner trials and the TAVR trials. So they were looking at comparing endarterectomy versus carotid stenting in over 1,200 patients, both with symptomatic and asymptomatic stenosis, because there's this debate about the value of revascularization at all in asymptomatic patients. And they looked at both a safety endpoint, which was the early 30-day composite endpoint, and then a post-procedural sort of efficacy endpoint. How did these patients do over time? And you can see that in the safety endpoint, this was a composite death stroke or MI within the peri-procedural period, was really no different. So establishing, again, the safety of stenting compared to endarterectomy. But the risks of what happened to the patients are different. So even though the overall risk was similar, you can see that there are a lot more peri-procedural strokes with stenting. I think this is appreciable. You have to manipulate your equipment past the plaque in order to do the procedure, whereas you get much better proximal and distal control before you ever instrument the plaque with surgery, whereas heart attack was higher with surgery because of general anesthesia, because of blood pressure swings, because of tissue factor activation that comes with surgery. And of course, cranial nerve palsies are particularly unique to surgery because they're manipulating the nerve and really doesn't happen with stenting. You can see just this visual, as the primary endpoint, really no appreciable difference between endarterectomy and stenting overall in the trial and cohort, and that's where the data really lies right now. The risks, though, when you drill down on them, are different, as we highlighted. And importantly, if we look at the age of patients, and it takes a second to digest this graph, so if you follow the yellow line, these are patients as they get older, analyzed for whether they tended to do better with surgery or better with stenting. And it crosses the line at around 70 years, with older patients getting into that endarterectomy or surgery seems to do better. And I find this somewhat counterintuitive. I would have thought that older patients would tend to do better with stenting. The way that I make sense out of it is that in an older cohort overall, they tend to have bulkier plaque, perhaps more peri-procedural risk to carotid stenting as you manipulate your equipment past the plaque. So in summary, just from the CREST outcomes, more MIs with endarterectomy, but more strokes with stenting. Younger patients seem to have improved efficacy with stenting. Older patients seem to do a little bit better with endarterectomy. They now have 10-year follow-up data that's showing this is a durable result. There was concern that the stents would be mired by restenosis, as coronary stents were. These are not drug-eluting stents that we put in the carotids, but that has not been the case. The WASID and SAMPRAS trials I want to mention because they illustrate how medical therapy has really improved over 10 years, over 20 years ago. So from 1998 to 2008, we saw, comparing these two trials, these are of intracranial stenosis, so I don't think they're necessarily related to carotid, but these trials illustrate how the stroke endpoints at 1 year dropped dramatically with specified optimal medical therapy. So in the SAMPRAS trial, as compared to the WASID trial, they're mandating Courage-style optimal medical therapy. So this is a trial where they're specifying blood pressure endpoints, statins, antiplatelet drugs. So all of the things we've talked about with optimal medical therapy, and that dramatically dropped the rate, the event rate, and thus the potential benefit to revascularization. And this is what's really led to the CREST-2 trial that's ongoing. And I mention an ongoing trial because it illustrates the presence of clinical equipoise as we approach these patients. It's really two parallel trials of stenting and surgery, each compared to optimal medical therapy, because as the last slide illustrated, the Sampras trial showed us we are in a new era of optimal medical therapy and a new natural history of these diseases when untreated, and so we have to reevaluate the benefit of revascularization, specifically in asymptomatic patients with severe stenosis. So when you get a question about an asymptomatic patient with severe carotid stenosis, you can know that there's an ongoing trial that's randomizing them to optimal medical therapy, so there can't be the right answer, has to be revascularization, okay? So I thought that clarified some of the points. Dr. Rosenfield from Harvard and a number of his friends put together the ACT trial. This was, again, trying to look at asymptomatic patients with severe stenosis, wondering whether carotid stenting was better than endarterectomy. And it really showed non-inferiority once again. It was halted due to slow enrollment. I think that was the real take-home. So it doesn't end up being as robust a statement for a trial. CMS reimbursement, I mentioned, not because I think the boards would ever test about this, how Medicare pays for it, but I do think it explains what, as we come away from boards and as we bounce what we hear here against what our day-to-day clinical experience is and what we see in our practice, I think how things are paid for does influence how people behave. And so even though a carotid stent is reasonable for any symptomatic patient with greater than 50% stenosis, and CREST showed equivalency between stenting and surgery, and both have guideline indications, the CMS is only reimbursing for patients who are at high risk for surgery unless you enroll in this CREST-2 registry. So you can see both people not doing it and doing it depending on their funding mechanism. And I think that introduces some confusion just around what our day-to-day experience is versus what specifically is indicated and what the data shows. So just for boards, to wrap up the carotid section, revascularization for in symptomatic patients, revascularization is indicated as a class 1 indication for patients with greater than 50% stenosis. Surgery gets a 1A, stent gets a 1B. They were showed to be equivalent in the CREST trial, but again, the funding mechanisms are slightly different. So unless the patient is clearly high surgical risk, if both answers are present there, and I don't think they would ask it that way given these characteristics, the answer is probably endarterectomy. In asymptomatic patients, it's reasonable to consider revascularization for severe stenosis if they have no major comorbidities. We're dealing with class 2 level recommendations. And I think the lack of contemporary data versus modern medical therapy is really highlighted by the design of the CREST-2 trial. So I would say that for asymptomatic patients, look for optimal medical therapy to be the right answer. So now we're going to switch to acute stroke, and we're going to learn about selecting the best therapies there. The mainstay of therapy for acute stroke is really thrombolytics. This is, of course, not for hemorrhagic stroke, but for acute ischemic stroke. The standard of care for treatment is within 3 hours. We've seen benefit from the ECAS trial out to 4.5 hours. Alteplase is the drug of choice, and use in the community is safe and effective. A lot of emphasis has gone into increasing awareness. I think it's one of the reasons you would see it on the boards, because it's only applied in about 5% of acute stroke patients, but it increases the chance of recovery dramatically with a number needed to treat of just 14. So this is a powerful therapeutic option that's underutilized, and there's a lot of movement to increase awareness of when you can use it. With lytics, I think the important thing is knowing when not to use it. And so here's a big long list that's there for your reference of exclusion criteria for thrombolytics. And I just want to highlight some of these. There are some differences between this list of exclusion for thrombolytics in the setting of stroke and the use of thrombolytics in the setting of STEMI. And we'll have a number of talks tomorrow in the revascularization section and we can talk about the differences between them then. You'll see that elevated blood pressure, if you're going to give thrombolytics, greater than 185/110. You've heard that a couple of times today, and I'll say it again in a couple of slides. Of course, active bleeding or non-compressible puncture, things that are going on in the brain, AVMs, cancers, aneurysms, you don't want to give those too. One of the sneaky ones, and I changed the question not to have this, I was told it was too tricky. The DOACs, it used to be you could just look at the INR and you'd know whether they were on warfarin effectively or not. But now, when you have all of the non-vitamin K oral antagonists, you have to look carefully for whether they're taking them, and the INR isn't a good screening mechanism for that. So any presence of those medicines is going to be an exclusion as a bleeding diathesis. So what is the best blood pressure? This question came up earlier with the hypertension talk. I heard, so less than 185/110 if you're going to give thrombolytics. If they're not a candidate for reperfusion therapy, we allow permissive hypertension. This is the brain trying to perfuse the umbra, the area around the infarct. And so we just treat for greater than 220/120, so much higher than we typically allow. And then otherwise, it's kind of dealer's choice. So early moderate reduction in blood pressure really didn't change a cause, doesn't generally cause neurologic decline. So if you get their blood pressure down a little bit, it doesn't hurt them. And then there was another trial, the Cossacks trial, that was really looking at continuation versus discontinuation. What do you have to do with their blood pressure medicine when they go home? So these are folks as they're recovering in the immediate post-stroke period. For the first couple of weeks afterwards, it didn't matter. Then, of course, they're going to need optimal medical therapy down the road. But if it's in that first immediate recovery period, then it's okay to keep their blood pressure medicine on board. Now, acute stroke intervention has undergone a powerful evolution over the last several years in the setting of stent retrievers. So the technology, the technique, patient selection have all dramatically improved the success of this. There are a number of trials showing how well it works. Mr. Clean is probably the best of those, most cited of those trials. The number needed to treat, if you look at this for functionally independent recovery, 3 to 7. I mean, it's a really powerful therapy. There's benefit out to 6 hours. This is beyond our typical cutoffs for thrombolysis. So there are patients you may see that can't get thrombolytics but can still benefit from the stent retrievers. We do have to know which patients are going to do well. I think a lot of this, again, comes down to logistics. So it has to be an intervenable vessel. So these are going to be bigger vessels, typically in the front of the brain. Think M1, M2, and these are little self-expanding stents. So it has to be a vessel that's big enough to instrument, right? So you get a catheter up into the vessel and you extrude these self-expanding stents. They grab hold of the clot and pull the clot back out of the area, allowing reperfusion. You can get a really dramatic Lazarus effect where someone who couldn't talk or couldn't move one side of their body, suddenly it's back as that brain wakes up. So it's a powerful therapeutic advance that's really happened recently. So once again, benefit out to 6 hours. It's really for large arteries because you have to be able to get your catheters up there. Angiography intervention can be performed even if they've already had thrombolytics. That's an important distinction. And then this is a role for coordinated care systems. We already do this for STEMI, and these networks for acute stroke intervention are popping up around the country. And I encourage you as you go back to your centers to think about who might do this and what to do with acute strokes. And so our final section is going to talk about renal vascular disease. Again, staying well outside the mediastinum, but we're going to see what to do with the kidneys. I think the important distinction here, when do we think about renal vascular disease? Well, really resistant, rapidly progressive hypertension often can be associated with flash pulmonary edema. These are patients that are marching up on 1, 2, 3, now 4 drugs, 5-drug hypertension, especially associated with renal function decline. You have to think about this in order to make the diagnosis. Usually the first step is ultrasound. Sometimes bigger patients, it's harder to see the kidneys. CTA and angiography also work. I would say that CTA is probably the mainstay for making the diagnosis. Ultrasound usually adds some suspicion. CTA confirms the anatomy. Angiography is most commonly done in the setting of attempted intervention. And this comes in really 2 flavors. The vast majority, 90% of the time, this is atherosclerotic disease. And so it comes, again, whole body atherosclerotic disease. It's a whole body process. It can manifest predominantly in the visceral vessels or the kidneys. It's not a male predominance, but it's going to be older patients. It's going to be in the proximal part of the vessel. Treatment basis is really medications more than stents. And then the other side of this is fibromuscular dysplasia. So when you see, this is a completely different demographic that's presenting with symptoms that are comparable to renal vascular disease. So hypertension in a young woman. Okay, you're going to hear something about a string of pearls, and I'll show you what the angiogram looks like. So the clues, again, worsening hypertension. They're now marching up their number of drugs required to control their blood pressure quickly, especially flash pulmonary edema. They're going to have peripheral or coronary arterial disease. Elsewhere, you can often hear a bruit. It's pretty neat to pick up. It is a strong predictor of mortality because the disease is everywhere, and so they have heart attacks, they have strokes. It's not because the renal artery stenosis is causing a stroke, it's that it's causing hypertension, and it's a marker of disease that's systemic. Now, the arc of renovascular hypertension and renovascular disease involves renal function decline, so chronic ischemic nephropathy, and where you intersect that arc with diagnosis impacts the likelihood of treatment benefit. There is this theory that if we intersect the arc too late, the kidneys really can't respond even by adding blood flow, and this likely explains a lot of the negative trials we'll just mention quickly. Here's a nice picture. It's got an arrow to show you exactly where the stenosis is, and just as an interventional person, it's just crying out to be opened. We have the ability to open this up, so really, why wouldn't we? But I want to draw your attention to a couple other things that are in this to flesh out the picture. Look at the left kidney versus the right, the sort of CT nephrogram, if you will. There's much less blood flow. You can see that kidney is a bit smaller. And then look at all of the disease up and down the aorta here. This is a patient with a lot of peripheral vascular disease. Now, it can be very satisfying. We just come up with a catheter, we put a stent in it. This is why there's so much enthusiasm for it. We see it, we can fix it, let's do it. It's just not that simple, it just doesn't work. And so just the natural history is hard to predict as well. If you look at less than 60% stenosis, about a third get worse. If you look at greater than 60% stenosis, a half get worse. It's not a big difference. They all tend to get worse because atherosclerotic disease is hard to halt completely. We all know that. And so who should we treat? There have been a lot of anecdotes about people with multi-drug resistant hypertension and renal decline, and they were kind of saved with a stent, or patients with recurrent flash pulmonary edema and renal artery stenosis that suddenly weren't having recurrent hospitalization. So it can help. Those patients weren't studied in trials. We got 3 trials, STAR, Astral, and CORAL. I don't want to belabor the data too much other than to say in the Astral trial, we had 400 patients in each arm. They're really looking to see if they could attenuate renal function decline. But again, where we intersect the arc of disease progression with diagnosis impacts the likelihood of benefit, and it just didn't work. You can see the curves that overlap tell you that there was no treatment effect over medical therapy. This led eventually to the CORAL trial saying, well, maybe we can do this better. Maybe if we target just patients with resistant hypertension, so a higher risk cohort. Again, it just didn't work. There are a number of sub-studies trying to look at different ways to predict which patients are going to benefit, but stenting of renal artery stenosis really is unlikely to be the right answer with really one exception. And Chris White uses colorful language, and he wrote a really interesting editorial where he said the authors are to be congratulated. This was in reference to the Astral trial. It takes a certain amount of courage to publish a trial so poorly conceived. He's not mincing words. But what he points out is that they excluded flash pulmonary edema, critical renal artery stenosis with acute renal failure, very severe uncontrolled hypertension. So there are these individual patients where there tends to be expert consensus that it's likely to help. The trials have all been negative. So if it's somebody who wouldn't have been included in the trial, you might consider it, but as a rule, it's not going to be the right answer beyond medical therapy. And so, 36-year-old woman with hypertension. Okay. This is why CT isn't the best way to make the diagnosis. It's better on angiography, which is the gold standard, and the treatment is balloon angiography, and it's one of the last bastions of pure balloon angiography. You can see the vessel to the left kidney is much better looking, and you can see what happens after you do angiography. So a balloon works here because it's just kind of a buildup of these septations. You break them as you push them out of the way. They tend not to recoil the way that atherosclerosis does with balloon angioplasty. And so by disrupting the pathology, you don't get a lot of recurrence, and it works very well. So that's the mainstay of treatment for fibromuscular dysplasia. Again, younger or middle-aged females with increased velocities. It tends to be in the body of the vessel or more distally rather than proximally, as we saw that renal artery stenosis. Invasive angiograms are the gold standard. You can often see a suggestion of this on CTA. The string of beads is that word association you have in your head for the test questions, and then balloon angioplasty is the treatment of choice. We're increasingly seeing this with patients who have spontaneous coronary artery dissection, or SCAD, and so in our SCAD patients, our practice has evolved really to gather more information by looking for FMD in those patients. Renal denervation, in a word, don't. It's never going to be the right answer at this point. Simplicity 3 was a large randomized trial. It was a sham-controlled intervention trial. You had to read a script, and it just didn't work. There was a lot of money and interest in this technology when it first came out. It seemed promising. It's based off a surgical procedure that seemed to work from a century ago. But for the boards, everything to this point is negative. Just I think it's not going to be the right answer. So some renal artery stenosis for the boards. Know the clues to its clinical presence. Remember that stenting and denervation aren't going to work. Look for the string of pearls. And then remember that some patients, it's not never the right answer, okay? So there are patients out there with recurrent flash pulmonary edema that it can help, but it's a select group that weren't in trials. Now, in summary, just to wrap up, we talked first about carotid disease. Remember, symptomatic patients are at much higher risk. We treat when it's greater than 50% asymptomatic. We talked about what is symptomatic. Remember the 6-month cutoff. And asymptomatic patients, so greater than 6 months since a symptom or no symptom attributable to that carotid plaque, greater than 80% is reasonable to revascularize. Remember, the CREST-2 trial is randomizing against optimal medical therapy. So I think that clinical equipoise in this new era of aggressive optimal medical therapy is there. When we talk about surgery or stents, a number of trials showing equivalency. Consider their surgical risk and consider the funding mechanism. And then for renal artery disease, the number of trials have been negative for stenting. Remember, balloon angioplasty for fibromuscular dysplasia. And with that, I'm going to stop. Thanks very much.
All right, come join me on the hot seat.
All right.
Excellent. Thank you very much, Peter. So we'll go over these questions and maybe a couple of other bonus ones that are here. So the question number 1 from the pre-test is, which one of the following represents symptoms relative to a carotid artery stenosis? Is it vertigo last week with a 90% right carotid stenosis? Is it ipsilateral transient monocular blindness 1 month ago? Is it hemisensory loss 1 year ago? Or is it expressive dysphagia 7 months ago? Or a combination of those? So 84% chose number 2.
All right. Much less than confusion than was before, so it's late in the day. I think
Good
we can.
job. Yeah.
The essence here is, remember, vertigo wouldn't be attributable to a right carotid stenosis, and then so the one right one here is the ipsilateral, and that's that was 1 month ago. The others were more than 6 months ago. So we try to emphasize that 6-month cutoff for symptomatic carotid stenosis and then the anatomic localization.
Yeah, that's a good question. Number 2 is a 73-year-old man referred 2 months after right carotid territory stroke affecting his left arm and leg with good recovery. He's got 100% occluded right internal carotid artery and a 40 to 69% stenosis of the distal left common carotid artery. What should we do? Do a right CEA to reduce recurrent stroke? Stenting would be a reasonable alternative if there are high-risk features for surgery. 3, carotid angiography should be performed prior to making a decision. Or 4, revascularization isn't indicated.
Great. I think most people got the point about complete occlusions. If you wanted to really push somebody with, I think the boards don't try to trick you, and this is, I think everyone's experience with the boards. They're well-written, vetted questions. If you find a question that's really seems tricky, it's probably a test question, not a real one. So if they say 100%, it's probably 100%.
All right, question number 3 is a 72-year-old male. He weighs 80 kilograms. He's got AFib. He's got new aphasia and hemiparesis. He was last known to be normal 4 hours ago. CT scan shows no cerebral hemorrhage and an M2 occlusion. Treatment center with expertise in stent retrievers is 1 hour away. His blood pressure is 170 over 100. His INR is 2.2. His blood glucose is 105. What should we do? Give him alteplase at 72, give him higher dose alteplase, transfer him for stent retrieval, give him the lytic and transfer right away, or give him the lytic and transfer only if he doesn't resolve within 1 hour. That's worth some discussion.
Great. I think what I was hoping for people to pick up on here, and this is where I'd originally written the question with a patient on apixaban with an INR 1.3, and I was worried that was going to be too tricky. But you could write the question the same way. This is somebody who has a bleeding diathesis in the form of being on presumably warfarin and an elevated INR, so he's not a candidate for thrombolytics. So any of the questions involving thrombolytics with an INR of 2.2 are the wrong answer. And that's why you can still transfer him for intracerebral clot retrieval, and we'll still do that with an elevated INR and just manage the groin carefully afterwards, put a closure device, something like that.
What's the time window for a stroke? I mean, how long can you, is it too late?
So there's been benefit with stent retrievers out to 6 hours. You have to factor in transport time in that regard. And for thrombolysis, it's 3 hours. There's benefit out to 4.5 hours. And some of that is based on their bleeding risk versus their stroke scale. And their NIH stroke scale is going to be used to fractionate their likelihood of benefit given the density of their stroke. So, and often it's very hard, so often part of the reason a minority of patients end up being treated with thrombolytics is we don't know when the last normal was. So establishing that time cutoff is, while very testable for the boards, practically speaking, it can be very difficult unless it's witnessed.
Yeah, so this would be, so even if you take the anticoagulation out of this is a tough patient because he's kind of near the end of his lytic window, and with an hour transfer to the retriever center, he's also going to push that depending on how quickly you can organize the transport.
Yeah, I would say this would be not unreasonable if he could to give lytics. He's within the 4.5 hours. If it was true, that's when he had benefit and a high likelihood of and then ship. So he would be someone that then, if his INR was acceptable for lytics, that you could give transfer, especially he's got a large anterior clot on the CT scan.
Yeah, and as you mentioned during your talk, there's a lot of these telestroke networks that have started now where stroke neurologists take care of patients at critical access hospitals and make that decision in the periphery about whether to give lytics before they ever get transferred, and it's helped a lot of patients get return of function sooner. So
powerful treatment modality and very new compared to even when I was in training. So this has been a strong evolution in the technology, the decision making, and telehealth has really grown up. We do that.
So I'm gonna go off script a little bit here and ask you the $5 million question, and it's posed by several people on the portal, and that is, you've got the person who has coronary disease and carotid disease, and they both are in the realm where you think revascularization of both territories is going to be necessary. How do you approach that practically?
Very good, and like all good questions, there isn't, I think, a single best answer. I think you have to look at their risk of ischemic burden for going through the carotid revascularization, and remember that, see if you can space these out a bit and see where they are with their medical therapy and how severe their coronary disease is. I think looking at their ischemic burden, the severity of their coronary stenosis will help and inform that decision as you decide can they, and what treatment is necessary for their coronary disease. They have multivessel coronary disease, perhaps a CABG with carotid endarterectomy is reasonable. A lot of patients remember revascularization of their coronaries in anticipation of another surgery doesn't help reduce events. Right. And I think that's an important message. I see this in the cath lab all the time. Should we treat their coronaries so they can have their renal transplant, so they can have their neck surgery, some other surgery, orthopedic surgery, and careful medical management can get somebody through their perioperative period with their myocardial ischemia much better.
All right. Great. We have time for a couple of more questions, so we'll put up question number 4. You were asked to calculate the diameter stenosis of a carotid lesion. Where do you measure the reference vessel diameter? A, B, C, or D?
Can't say I didn't warn you. I think 91's pretty great.
That's pretty good.
I think the next slide shows the cartoon and how we do this. This is the distal reference vessel is for the internal carotid. So a little of this was knowing internal versus external, and this was the first question on my board, surprising or not. That's why I think it's worth including. They had this picture and we were asking about it.
All right, let's go to the next slide. There's the cartoon. And question number 5, from randomized trials, the approximate yearly rate of stroke with asymptomatic severe carotid stenosis is which of the following? 1, 3, 5, 10, or 20%?
It's 3. I tried to tell you it was coming. I think the more important thing to know that in asymptomatic patients, the surgery only improved it from 3 to 2. That's what I put on there. So, and then medical therapy is different now than that era, and thus we have, I think, a new era of equipoise.
Excellent. And then one last question here. It has to do with what's considered a high-risk feature for carotid endarterectomy. All of these are high-risk features except for one of them. Is it coronary drug-eluting stents 3 months earlier for non-STEMI? Is it prior endarterectomy with restenosis? Is it inability to flex the neck? Is it being older than age 80? Is it dialysis-dependent renal failure? Or none of those is true?
You're picking the one that's not a high-risk feature. I believe in you. It's late in the day, but you can... Well, it's late. So I try to emphasize that the surgeons will often operate on dual antiplatelet therapy. 3 months after an NSTEMI, if you're thinking about the heart attack, they look the high-risk features within 6 weeks. I think a couple of slides down, I highlighted all the ones that are there on that. Mm-hmm. On that, there they are. So those are all the high-risk features, and this is how they were enrolled in trials, and especially the Sapphire trial. Yep.